IV skills. IV therapy is one of the most challenging of all nursing responsibilities. It requires close monitoring of the IV solution and the site to prevent complications. As practical nurses, you have to know the scope of practice in which you're allowed to practice. Currently in Kansas, you can monitor existing infusions, you can monitor existing sites, you may provide maintenance care to existing sites, and you can discontinue peripheral sites that are less than 3 inches long. If a practical nurse has taken an IV certification course, they can also initiate IV sites, hang replacement bags of IV fluids, piggyback additives into primary fluids, and push some drugs directly. But again, you have to take an IV certification course. IV infusions can consist of primary or secondary lines and peripheral or central lines. The primary line is going to be your main line IV fluid. A secondary line is plugged into the primary line at some injection port. A peripheral line is in the arms, legs, or jugular site and is less than 3 inches in length. A central line is placed in the arm, leg, chest, or neck and has a long catheter that reaches toward or rests just inside the heart. IV therapy supplies are all basically the same, but you need to be familiar with your facility supplies. Most IV catheters will have a safety feature that will retract the needle once the catheter is placed or is ready for disposal. During client assessments, you will need to assess all IV fluid solutions hanging, including piggyback medications, and make sure that the piggyback medication has been infused if it's not currently infusing. Assess drip rates of all IV solutions, assess IV pump for accuracy, assess IV tubings, and assess the IV dressing and insertion site. Mainline IV tubing consists of a drip chamber, a roller clamp, 1 or 2 injection ports, an auxiliary clamp, and needle attachment with a Luer lock. The drip chamber contains a covered vent. If hanging a solution contained in a glass bottle, this vent should be opened. The tubing contains an average of about 15 mL volume. The roller clamp must be closed prior to spiking the IV bag. Once spiked, then the drip chamber is squeezed until it's about half full. The roller clamp is then opened and the tubing is primed or filled. You work large volumes of air out of the tubing. A little bubble here or a little bubble there is okay, but large volumes of air must be worked out. The injection port closest to the drip chamber is what is going to be used for piggyback medications or bolus infusions. The injection port that's closest to the client will be used for IV pushes or bolus infusions. If an IV solution bag is allowed to run dry, it will draw air into the tubing. You should clamp the tubing below the air pocket. Hang a new IV solution bag. Place an empty sterile syringe on the injection port below the air pocket, and with the syringe pull the air out of the tubing and then remove the syringe. This is a picture of secondary tubing. It consists of a drip chamber. It may have an auxiliary clamp of some kind, a needle attachment with a Luer lock, and a hanger. Make sure that the auxiliary clamp is closed prior to initiating priming the tubing. Piggyback systems have your mainline IV fluid, and unless it's placed on an infusion pump, it's infused by gravity. The higher the bag, the faster it will flow. Whatever bag is placed highest will infuse first. And you can see some backflow if the bag level is not appropriate. When hanging piggyback medications, you're going to lower the mainline bag with that plastic hanger. Hang the piggyback medication higher and adjust the set infusion drip rate. Once the piggyback medication has infused, then automatically the main line will kick in. But you should clamp that secondary tubing to prevent the mainline fluid from backflowing up into the piggyback bag. If a secondary IV solution is to be infused, it should be connected at the injection port closest to the client. The second IV solution is run concurrently with the primary IV solution, and the same tubing is utilized. Excuse me. Using a label or a piece of tape, you will identify the tubings as to which solution is infusing through them closest to the connection site. Again, the height of the bag is going to affect the drip rate, and if you change the height of the bag, the drip rate will require recalculation. Of course, if you're infusing solutions by a pump, then this doesn't really make any difference. Unless IV solutions are running through the IV pump, solution bags should be at the same height if you're running a secondary solution. This is what's called a diloflow regulator, and they're very helpful if you do not have an infusion pump available. It can help regulate the drip rate. If you look, you can see numbers on the cylindrical portion of the tubing there, and it helps regulate the rate at which the fluid passes through the tubing. You prime the tubing, you adjust the regulator to the desired drip rate. Now, they are not 100% accurate, and they do require hourly monitoring to make sure that the drip rate is appropriate. Again, if you adjust the height of the IV bag, then you should probably look at it again and make sure that it's infusing at the rate you want it to. This is a burette set. It allows for accuracy in administering small volume amounts. It is a standard of care when you're doing IV infusions in infants and children. You close the roller clamp, spike the IV solution bag, and using the burette chamber as a drip chamber, you're going to place a small amount of fluid in the chamber. And when you're infusing fluids to children, the standard is to fill your burette chamber with the amount of fluid that will infuse in an hour. Prime your tubing. If you have not already done that, the device has to be refilled if additional solution is to infuse after the hours is up. This is an extension tubing and a cap. It is frequently attached to all IV catheters to provide ease of use, and the auxiliary clamp should be closed between uses. This cap is a needleless system, and you just screw the syringe onto the cap instead of using a needle. Standard IV start kits are available, which contain a tourniquet, alcohol, or some type of cleanser, tape, 2x2 gauze, a bio-occlusive dressing, and a label. It's not required to start an IV, but it does save time and is easier. There's a variety of IV catheters available. They are sterile. If you use an angiocath, the size is frequently determined by the color of the catheter. An angiocath is what you see in the upper left. Safety catheters are available. If you look at the angiocath in the upper left, you see that little white button, and you push that button, it retracts the needle and leaves the catheter. Once the vein is accessed, you do remove the needle, and that flexible plastic catheter remains in the vein. The butterfly catheter in the lower right is frequently used in blood draws by lab personnel or short-term IV infusions. The needle does remain in the vein during use, so infiltration is very common. A Huber needle, which is in the lower left, it has that needle that is bent at a 90-degree angle. Come in a variety of sizes, and they frequently have tubing with a clamp attached. Huber needles are used to access portacaths These are central intravenous lines that are implanted in the chest. This device usually stays in place for an extended period of time to maintain IV access. This is a central line device and it requires central dressing change protocol. Dressing and IV maintenance is established by each facility. They have their own protocol concerning frequency of dressing changes and IV cath changes. Standard is now going to be every 4 days versus what a lot of facilities still use as every 3 days. You have to maintain sterility with dressing changes. There's a variety of taping methods that you can use. Just make sure that when you're taping and placing bio-occlusive dressings, removal of the dressing can accidentally dislodge IV devices, so you need to be extremely careful how you place the tape and the dressing. The insertion site should always remain visible so you can monitor it. Many clients are very sensitive to tapes and adhesives, so make sure you use the appropriate type. Paper tape and Metapore tape are usually tolerated better than others. IV sites can also be secured with Kerlix or Coban, especially if you have a patient that is constantly picking at the site. Routine dressing changes will decrease the infection rate, but increases the risk of infection. Again, most recent literature states that 96 hours or 4 days is appropriate, but standard has been 72 for many years. IV dressing changes are sterile procedures. There are central intravenous dressing kits available that contain gloves, mask, bio-occlusive dressing, gauze, tape, cleanser, and label, and all of those are sterile. A peripheral dressing change is usually completed with a start kit, or you can just grab a new bio-occlusive dressing, tape, and alcohol swabs to cleanse the site. Peripheral IV catheters should be changed every 72 hours or per facility protocol to reduce infection risk. But if a client is difficult to start an IV on, sites are frequently maintained as long as possible. Peripheral lines, make sure you get all your supplies ready. Tear that new tape prior to beginning your dressing change. Carefully remove the tape and the dressing, holding that catheter secure, and cleanse the site thoroughly with alcohol swabs and allow it to re-dry. Retape the catheter and apply a new dressing and label. IV locks should be flushed routinely to maintain patency per facility protocol. LPNs are not allowed to do this without a certification class. Without routine flushing, a blood clot can form on the end of the plastic catheter, so that's why we do the flushes. During continuous IV infusions, IV sites have to be monitored routinely and according to facility protocol. During continuous infusions in infants or children, those sites should be monitored at least every hour. If a caustic agent is being infused, peripheral IV sites should be monitored at least hourly, if not more frequently. IV tubing is to be changed routinely per facility protocol to reduce the risk of infection. Again, usually 72 hours is standard, but if you're infusing a parenteral solution or TPN solution, that needs to be every 24 hours. Tubing should be labeled appropriately so you know when to change it. And again, with tubing changes, maintain sterility. There's a variety of infusion pumps available that will assist in providing accuracy in delivering fluid volumes at appropriate rates. It's still necessary to monitor the IV infusion rates with the pumps. Most pumps are designed to interrupt the mainline infusion to administer a piggyback medication and then return to the mainline infusion once the piggyback is done. The infusion pump should be cleared at the appropriate times to record intake and output. The mainline tubing is appropriately threaded through the machine, and then the primary solution is programmed into the pump. When mainline tubing is appropriately connected to the client, then you turn the machine on. You are unable to run two IV solutions concurrently through most infusion pumps, although there are some that can do several. When you're troubleshooting these machines, make sure that the machine has been turned to run. Make sure that all clamps have been opened. Make sure that the tubing is not kinked. Check your IV site. You might need to straighten the client's arm or wrist. And then we have mini infusion pumps, such as what is shown on the right side of your screen. Mini infusion pumps are ideal if a small volume of medication needs to be infused over a specific period of time. It does require tubing that's specific to the pump, and you can also set these pumps to alarm when the infusion is complete. The tubing does connect to other IV connections. Patient-controlled anesthesia requires, this is where you're administering pain medication through the IV and the patient has control of it. It requires a primary IV infusion, infusing at least a TKO or KVO rate, which is to keep open or keep vein open. 25 mLs per hour is pretty average. A short pigtail tubing is located a few inches from the needle attachment, and it has an auxiliary clamp. The IV infusion tubing is attached at that pigtail. You provide the clamp with a PCA button, and then you provide them with the PCA education. The PCA pump is set according to what the doctor orders. The medication can infuse continuously. It can infuse continuously and have bolus doses administered by the client when they push the button. Or medication may be administered in bolus doses only when the client pushes the button. The pump is programmed to provide a certain medication dose at prescribed intervals with a prescribed 4-hour lockout dosage. Excuse me, in other words, it's very common. You have morphine as your medication, for example, 1 milligram every 10 minutes with a 24 milligram 4-hour lockout. So they only get 1 milligram and they can only get it every 10 minutes. Now they can push that button as often as they want, but the machine will not administer medication if it has been less than 10 minutes. So the client will push the button whenever they feel like they need the medication, and the medication will be administered if the timing is appropriate. If it reaches the 4-hour lockout prior to 4 hours, the machine will not administer another dose until that 4 hours has been elapsed. The medication vial and the infusion control panel are locked, so the patient or patient family cannot mess with it. The machine is cleared routinely, and the dosage is recorded in the patient's chart. Make sure that the family and friends do not push the button for the client. The nurse and the client are the only ones who should ever push that button. If a client is unable to push the button, they usually don't require any medication, except at the nurse's discretion. This will help prevent well-meaning over-medication of the client by family and friends. Be familiar with the labeling on IV solution bags. If you look at the one on the left, 0.9% sodium chloride is also known as normal saline. 5% dextrose would be D5 or D5W. LR is lactated ringers, or RL. Either one are appropriate. 1/2 normal saline would be 0.45% sodium chloride. D5NS would be 5% dextrose and 0.9% sodium chloride. D5 1/2 NS is 5% dextrose and 0.45% sodium chloride, etc. Be familiar with what you're looking at. IV bags should be labeled with the client's name, account number, room number, etc., and the order per facility policy. If it's a manual infusion, you're going to place tape along the calibrations that's located on the IV bag, and you will determine what times the amount of solution in the bag should be at. For example, the infusion is 150 mLs per hour. After 1 hour of infusion, the level should be at 850 mLs. After 2 hours, the level should be at 700 mLs. This helps you determine, looking at the bag quickly, if the fluid is infusing at an appropriate rate. Piggyback solutions can come in a variety of sizes, 50, 100 mL, sometimes 250. Many piggyback drugs are available pre-mixed, or they've been mixed by your pharmacy personnel. It's important to use pre-mixed solutions when possible to help prevent any medication errors. There's also an Advantage system, and if you look in the lower right, you see a bag that has a large white piece on the top. It allows a vial of medication to be screwed in. Then underneath that vial in the bag, there's a little stopper that has to be removed, which will allow the medication to be mixed. It's very easy with these Advantage systems to inadvertently forget to mix the medication. So it's very important to make sure that that stopper has been removed. When you calculate drip rates, you calculate in drips per minute. You divide your drip per minute rate by 2 or 4. The result should equal the number of drips falling in the drip chamber for 30 seconds if you divide it by 2, or 15 seconds if you divide it by 4, to obtain the appropriate drip rate. So for example, you have an IV infusion rate that is 125 mLs per hour, and you have a calibration set at 15 drips per ml. So this would equal 31.25, or 31 drips. You divide 31 by 4, and that's going to equal 7.75, rounded up to 8. And then you're going to hold your watch up to the drip chamber, and using the roller clamp, adjust the drip rate so that you have 8 drips in 15 seconds. So to get your drip per minute, you'll take 15 drips over 1 ml times 125 mLs over 1 hour times 1 hour over 60 minutes to get your drips per minute. That will equal 31.25. Infiltration of IV solution is the leakage of fluids into the surrounding tissues in addition to, or rather than, the blood vessel. So sometimes it will infiltrate while it's still going in the vessel, but sometimes it is going into the tissues only. Signs and symptoms of infiltration: you have some edema in the suspected area, and you may observe some pitting edema. There might be redness. There might be pallor rather than redness. The site will be cool to touch, and you may not be able to blanch the site. You may see blistering, possible pain. The IV solution is not running, or the IV pump is alarming because it has increased flow resistance, or the IV solution is running out of the IV site. Stop the IV fluids immediately and remove the IV catheter. You should elevate the affected extremity and apply some cold compresses. Restart a new IV site if the therapy is to continue, preferably in the opposite arm the infiltration is in, and it should be above the infiltration site. Depending on the extent of the infiltration, it can cause some tissue damage and even necrosis, depending on the medication. One medication that is well known for causing necrosis would be dopamine, and we treat that by monitoring it closely And if an infiltration occurs, then we can inject the site with Regitine. This is one infiltration site. Another. Notice the swelling, the tautness of the skin. Tissue damage. Blistering in an infant. So to remove an IV site, you need to turn the IV roller clamp off. Remove the IV dressing and tape very carefully in the direction of hair growth if at all possible. Apply counter pressure as that dressing is removed to help prevent any tissue tearing. Clean the site with an antimicrobial swab. Place a sterile gauze above the site and withdraw the catheter. Apply pressure for about 2 to 3 minutes with gauze, but if the client is on blood thinners, you may have to apply pressure for 5 to 10 minutes. Inspect the catheter for intactness and apply a clean folded gauze to the site and secure or a cotton ball, observing for any bleeding, redness, pain, drainage, or swelling.